going. Great. Welcome to our session today on the quality infrastructure elements, integrating equity into quality practices, and engagement of patients, partners, and the community. So this has really, in my career, become one of my favorite topics because I feel like this is where we can really make some changes into the health of our communities. So my name is Jennifer Wagner. I'm the Director of Rural Health Initiatives at Convergence Health. And today we also have a special guest with us, Lindsay Galley with PFCC Partners. Lindsay, would you take a minute and introduce yourself and the role that PFCC Partners plays?
Yeah, absolutely. Excuse me. Hi, everyone. I'm Lindsay Galley. I'm the Vice President of Programs at PFCC Partners. Our organization has been partnered with Convergence for the last 5 years to bring all things patient family engagement for equity to the work that Comagine is doing to support your hospitals too. So really keeping patient family engagement for equity at the top of mind. And we say patient family engagement for equity because we know we can't get to a place without equity, without engaging people, patients, family caregivers who are experiencing those inequities. So I'm really excited to be here with all of you and Jennifer. So thank you for having me.
Thanks so much, Lindsay. My apologies if I seem a little scattered. Right before I came on, all my monitors went weird. So I'm working like not in like my habitat today. So I will do my best. So if I'm looking in the weird places, my apologies up front. But anyway, so first, before we get going, I just want to, for anyone that's new to this series, give a quick background to what the quality infrastructure is. So last March, we had national partners for the Rural Hospital Flexibility Program that convened a group of cost staff, state flex programs, hospital and healthcare association staff, and also several quality consultants and quality program subcontractors for the purpose of identifying the attributes of a strong quality infrastructure and critical access hospitals. I was incredibly honored to be included in this group, so this is really fun to share what we have come up with and what we have to support our hospitals. I want to give very special credit to the Federal Office of Rural Health Policy. They fund the FLEX program, as well as the FLEX monitoring team, the National Rural Health Resource Center, and Stratus Health. These organizations were really key to developing a well-informed and valuable resource and data source for rural hospitals and programs that support them. These people really, truly understand and care about rural health quality. And like I've mentioned before, we'll provide links to the report so you can read it in its entirety and get the full context. And also, while you'll hear cause or critical access hospitals noted throughout the report and the assessment, the content can really apply to all rural hospital quality programs. So today we're going to be talking about the elements in orange, integrating equity into quality practices and the engagement of patients, partners, and community. These elements really intertwine with each other. However, they're the lowest scoring elements throughout the country, which kind of makes sense as this is areas where hospitals are just starting to explore. So I hope what you hear today inspires you to think of ways that your hospital can build these elements to strengthen quality and patient care. As we go through, please feel free to engage in the chat or unmute and ask questions of myself or of Lindsay. And a reminder that these elements and the criteria are going to be nuanced in your state or even your hospital. In this series, it's a condensed piece of information about these topics, and it's just kind of a way to give the broad overview. For each of the core elements, there are 2 to 4 criteria that list ways these elements can be met or demonstrated. And to meet the element, a hospital must meet each criteria. And we'll go over the variety of ways that criteria can be met. So we're going to start with integrating equity into quality practices. So this means that to undertake intentional improvement activities to ensure a fair and just opportunity to be healthy as possible for all community members. This is the lowest scoring element, as it's really difficult to start work on. And I feel like all our hospitals are in this, like, what do we do? And so I hope that we can help you identify some things to do throughout today. Before we start, it's really important to understand some key pieces of equity and health equity. So first, I want to talk about the distinction between equality and equity. And you've probably seen similar graphics before, but I still want to touch on it. So equality means that everyone receives the same treatment or resources regardless of who they are or what they need. So equality is everyone getting the same bike, even if the bike only functions for one person and can't function on different paths and for different abilities. Equity means that everyone gets what they need to be able to do the same thing. So we understand that there are unique circumstances that require different treatment and resources. So equity is everyone getting the bike or mobility resource they need for the path they're on. Now, health equity. So given that the World Health Organization has actually declared health as a fundamental human right, it's really important to ensure that it's equitable. And I like to use the Robert Wood Johnson Foundation definition of health equity, that everyone has a fair and just opportunity to be as healthy as possible. And where we can start coming in as healthcare systems and providers is helping remove the obstacles to health, such like poverty, discrimination, powerlessness, lack of access to jobs with fair pay, education, housing, safe environments. So while we can't maybe address, like fix the whole thing, we know that these are obstacles for individuals and we can help work through those obstacles. Equity is also one of the 6 domains of healthcare quality, with the intention that hospitals provide care that doesn't vary in quality because of personal characteristics such as gender, ethnicity, where you live, or your socioeconomic status. So for this element, these are the 3 criteria of the element. Managers are use collected data and other resources to identify inequities. Leaders routinely assess quality interventions and processes to address identified inequities. And units and departments implement specific health equity projects to improve care and lessen inequities. So we are at the beginning of that collecting data, and we really haven't gotten to the point where we're turning that data into action, as you can see even from the data here, but everyone's kind of on that road to that, which is really exciting. So criteria 1, managers use this data and other resources to identify inequities. The data can be internal or external. And the data we look to help identify these inequities includes race, ethnicity, and language, or real data, sexual orientation and gender identity, or SOGI, and health-related social needs or social drivers of health. External sources include public health and state national databases, and internally you may get some of this data from Z codes or your social drivers of health screening. And I really want to recognize that this can be sensitive for patients to share. So one thing that hospitals can do is provide training for staff to collect this data and help get staff comfortable in it. This is a great improvement project in a PDSA cycle, but even though it's difficult, it's still important to address the inequities, address what is needed to help eliminate the stigma associated with this. The purpose of collecting these data is to ensure that the hospital has accurate information that can be used to improve care and develop targeted QI projects that address these inequities and ultimately close the gaps. Criteria 2 is where we start to pull this data into action, and we have leaders routinely assessing quality interventions and processes to address identified inequities. So we collect the data, now we can use that to stratify our quality metrics using a different lenses of equity to ensure we aren't missing something. It's important to stratify all the data that you look at for whatever measures you're working on and use that information to identify further opportunities for improvement. So this figure just displays a variety of equity lenses, and identifying that specific equity lens or lenses allows for quality improvement projects to really capture the experiences of that population. And there might be also inequities that already exist in your initiative that you can pull out right away without looking at the data. An example I'll give of using this equity lens is, for instance, your overall readmission rates might be low. But if we stratify those rates by one of these equity lenses, we may see higher readmission rates for our non-English speaking patients, but low readmission rates for English speaking patients. So there really is a place that we can improve, right? So now we can start evaluating the readmission data and look at ways that we can revamp our discharge materials in languages that reflect the population or provide interpretation services as an effort to address the inequitable readmission rates found in non-English speaking patients. So that's just an example of ways how stratifying that data can be really helpful in identifying areas that we can still do improvement, even if that big aggregate number doesn't reflect that. This graphic is from our partners at our friends at PFCC Partners, and I really love it because it really demonstrates how effective this is. So we collect the data, and that tells us what we have going on, what the problem is. The people tell us the why, and without the data and the people, our patients, families, clinicians, and community members, we can't determine the how. So we need to work together to determine how to improve that. Criteria number 3, the units and departments implement specific health equity projects to improve care and lessen inequities. Again, I want to acknowledge this is really hard work, and we're all different boats, but we're in the same ocean of work on these efforts. So they are important efforts, and when it seems like everything else has failed, I really believe that this work helps us move together. So how do we even start to identify health equity projects or lessen those inequities? Well, the National Academy of Medicine has published a social care framework, and we have it linked in the resources, but our colleagues at PFC Partners put together this great graphic of the framework and the 5 A's of social drivers. And I'll let Lindsay jump in if there's anything I missed or anything I miscommunicate. So our first is awareness. This is doing our screenings and collecting data. And we do these activities to really understand where inequities and disparities are, but it's really only the beginning. The second A is adjustment. So shaping how the hospital can work in the community to create community-based solutions. One example that PFCC Partners has shared with me is is the bus stop story, where they had a hospital had patients that were late for appointments or missing appointments. And they found out that the bus stopped quite a ways from the clinic, and it was a really long walk for patients to get there. The bus wasn't dependable on time, so often patients were late or missed their appointment because of the bus schedule and the subsequent walk. So the hospital worked with the community to add a stop and change a stop to the clinic. And with this, the missed and late appointments nearly went away. So just that partnership within your community can really make a huge difference to meeting your patients' needs. Our third A is assistance. If the hospital does not have the capacity or ability to take care of a patient's non-medical needs, and I know many are worried, especially our rural hospitals, about the bandwidth to do so, you can build connections with the community and connect patients to those community resources. Maybe make arrangement with transportation. With the hospital gives a referral to a transportation service, they get a discount for a certain amount of time. This may also evolve into a long-term arrangement that is mutually beneficial for both the hospital and community partners to provide connections to the patients. In one of our Montana communities in Glasgow, they identified transportation as a need. And once they started digging into that, they discovered that a transportation service in town had needed customers or to meet volume and everything. And so they were able to work out a mutually beneficial arrangement to help get patients to their appointments. Our fourth A is alignment, working closely with community partners so that our activities and funding and services work together and are not duplicative or competitive within the community. Like, how can we harness all of our funding and our resources and our connections to spread that access and that benefit to community members? Oh, shoot. Sorry. Our fourth A is advocacy. So hospitals can work with organizations in the community to harness that collective economic and political power to influence changes in policy or changes in access and resources that improves equity needs related specifically to the community. And so not only can this framework help guide your action planning. It also provides some context and language to hospitals to help communicate with patients about why you are collecting this information and how it can benefit the community as a whole. I know many of our hospitals struggle with how do we communicate to our patients why we're asking these really personal questions and our social drivers of health screening. And this is just a piece that you can help communicate that so they understand the benefit to the community and to individuals. Lindsay, do you have anything to add? Have I missed anything on the 5 A's of social drivers? I think they're really important.
No, I think you did a great job, and I loved the examples too. I just think, just to add on, we've heard from not only hospitals, but also patients and family caregivers, and sharing this framework, how it, kind of simplifies the things that you need to do around screening and addressing for social drivers of health. So just encourage, hospitals to utilize the framework and take it one step at a time. It doesn't have to be all or nothing. Just take it in bite-sized pieces, small steps forward in order to, keep moving and addressing these.
Thanks, Lindsay. I want to leave this section with this statement that equity work is fundamentally quality work. We can't serve our populations without reflecting the population being served. And this is a quote from Toyson Boyo, who is the Senior Vice President of Hospital Operations at John Muir Health. So we can't address equity without the other piece, and that is engaging people, our community, our patients, our families, and our caregivers. And this brings us to the cleanest segue ever into the next element of engaging patients, partners, and the community. So what we see in this element is that the hospital builds external relationships with patients, partners, and the community to enhance and improve the care experience. We have 52 of our hospitals completing the assessment that can demonstrate meeting this element. As we go through this section, you'll hear the phrase PFE, which is patient family engagement, or PFEE, which is patient and family engagement for equity. And I want to start off by saying that this is really an active strategy to reach improvement goals, because we want to incorporate that continuous feed of patient and family perspectives into QI work. And when we bring in PFEE into our work any way we can, we not only work more efficiently, but we have more valuable information to design improvement. Just like we can't do improvement without bringing the frontline staff, our patients are the other piece of that puzzle, or that scenario. So we can't really improve without bringing some of their experience and their perspectives in as well. We really want to embrace that idea that people have concerns and people have experiences, and we all get farther when we listen and learn so that we can address those. Our 4 criteria for this element are: the first, the organization collects feedback beyond patient experience surveys. The second, the organization collabs with other care providers using closed loop referral processes to ensure the quality of care. So our providers are working together. The organization uses a variety of mechanisms to share quality data with patients, families, and the communities. Are we being transparent in what we're doing and celebrating what we're doing? And then leaders can synthesize and develop those action plans in response to patient, family, and community feedback. We have a question, Jenny. Where did you say resources for communicating with patients during the SODH screening was? Well, we have those 5 A's, but there's a variety of other resources out there, and that Convergence and PFCC partners have developed. And we can link some of that in the follow-up email for you. So our friends at PFCC Partners have also shared this slide for a really simple way to understand the work. So our patient family-centered care, or our patient-centered care, is the noun of what we're working on. It's the model care that is moving health forward. So if PFCC is the noun, our patient family engagement is the verb, reiterating that this is a really active strategy that, when applied to healthcare priorities, we have outcomes such as better healthcare, better patient experience, integrated care, increased patient safety. and increased outcomes, health outcomes for our patients. So it's incredibly valuable, and I think a really effective way to move that needle where I feel like we've seen the needle's kind of been stuck. And this is where I believe is really the missing piece to that. So criteria one, collecting feedback beyond the patient experience surveys. So we know that patient experience surveys or HCAHPS or any kind of CAHPS surveys are not always the best method to get feedback from patients. They do serve a purpose and provide aggregated data and the ability to see trends, but that data is often delayed and really hard to analyze in our rural communities with small volumes. And plus, we don't get the entire picture. So there are other ways that are more timely and they're more actionable and more engaging, and they also build trust and relationships with your patients. So we can look at bedside shift reports, using that theory, nothing about me without me for the patient, focus groups, rounding, having a formal patient advisory council, and then continuously integrating feedback and lessons learned from that. And we'll encourage you to really go a step further on this last one about integrating feedback. We want to integrate the people, not just their feedback. So having that person directly involved in your initiatives, and participating in the improvement team, you'll really get a deeper understanding of the patient's experience. And then this also models a really positive culture of collaboration within the facility and the community you serve.
And Jennifer, if I could just jump in with an example. I was just on a call yesterday with health centers and hospitals in Los Angeles County. And one of them, they have an advisory council, and their patient family advisors take like an hour out of their day to just walk around the center and have quick conversations with patients to ask. I was trying to find their questions, but just making sure that their needs are addressed, how their communication with nursing staff and physicians are going. And then they bring all of those comments back to their advisory council, where quality committees and patient experience committees can listen to it. So even if your staff has, which I know it's hard, but a few minutes out of your day to do some of that rounding and have those quick conversations, it's a really quick way to get that real-time insight from patients and families. So I just thought that was a good example of a kind of low level, low effort way to start engagement.
That's awesome. And when you were telling that, Lindsay, I was thinking it's also a great way to then be able to, if there's any issues or problems come up, you can address those immediately and not have to look back 6 months after you get your HCAHPS survey to know there was a problem. So you can
Exactly.
fix things before they even become a problem. And on the other side of that, you can immediately celebrate your staff that's doing an amazing job, and help that engagement and help alleviate some of that burnout that they may be feeling. Criteria number two, collaborating with other care providers using closed loop referral processes to help ensure quality of care. So this is really focused on that care coordination, and helping bring access and needs to the patients in the community. So this can be done through, as I said, care coordination services by facility staff, community health workers, or community paramedics. These models have all shown to provide reduced readmissions and improved patient outcomes. In the resources, you will find information about community health workers and community paramedics if your facility doesn't use those resources or doesn't have a partnership with any roles like that. But also in the resources, you'll find a care coordination toolkit from PFCC partners called Ready, Set, Go. And Ready, Set, Go connects really the process between admission, the bedside rounding, and the discharge planning to better coordinate care. Also included in this is the patient engagement map that's for your patients, and it's a guide with stops along the care journey that patients can engage and enhance their understanding of what they're receiving for care, and enhance their provider's understanding of their questions, their needs, or any clarifications. So these are some really great resources that will be linked with the presentation also.
Yeah, and I'll just say that that is a completely co-designed tool. We talk to hospital staff, we talk to state hospital partners, we talk to, of course, patients and family caregivers. So really have all of those perspectives represented in how this tool was built. And I just think a good example of what, co-design with patients, families, clinical staff, you need all of those voices to really develop something that's going to meet everyone's needs. So excited to share that with everyone.
Absolutely. It's an amazing tool. I'm really excited about the patient engagement map. I feel like it empowers us to speak as patients, to speak up to our providers and provide and ask for clarification or make sure that they know something. Because I feel like sometimes a common thing is that we, put providers on a pedestal and forget that our doctors are human and that we can ask questions and we can advocate as patients. Criteria 3, oh, I better talk faster. This element is, if you guys hang out with me, that would be great, but I'll go a little faster. Using mechanisms to share quality data with patients, families, and the community. You can use social media, newspaper articles, website newsletters, all those traditional things. Even putting a public-facing quality board in the facility, it holds the facility accountable. It shows your community that you care about certain issues, that you're working on them actively. And so those are really simple ways to build that back and forth feedback and with your community and your patients. So the fourth criteria, leaders synthesize and develop action plans in response to patient, family, and community feedback. So this really is important to engage our patients and families to inform the work of the strategic priorities of the organization. So we can have advisory councils, listening sessions, focus groups, storytelling, inviting patients that have had a good or bad experience to share with your board. Patients, families, and caregivers are an excellent resource to the work and priorities that currently exist in your hospital. And we want to encourage that spirit of problem solving and collaboration when we're working together. When I've talked with rural hospitals, they often tell me that they are taking care of our friends and families, and we have to look out for each other. And a lot of slogans for hospitals are caring for our neighbors, etc. And this is true. So let's harness that strong value of a close-knit rural community and really work together to encourage change and collaboration and improvement. When integrating patients and family and community feedback, you can get creative. In everything you do, ask how can the PFEE perspective give us the full picture? At one of our hospitals in Montana, I don't know if Sydney Healthcare is on the line, but they have groups that do walkarounds. They grab some patients, community members, they walk around. They have identified that my favorite, and it always makes me chuckle, is there's a bush in front of the hospital that it looks cute, but when the wind blows, as it does in eastern Montana frequently, all the litter blows into that. And so they recommended removing that so that you didn't have a landscaping with garbage at the entrance of your facility. They discovered there is some signage that, as staff, we get so used to saying the same things. We're not even probably really seeing the signage, but things had changed and the signage needed updated. And so these little things that enhance our patient experience and enhance the way that we work in our hospital are really valuable, and it can be really small and you can be really creative about it. Engaging also increases the trust with our community and improves relationships. We can't support a healthy community if our community members work in silos. So we need to engage and trust and collaborate together. So we have some core competencies of effective partners. Since we're close on time, I'm not going to go deep into them, but we want to have partners that work with establishing partnerships, do constructive collaboration, not just whining, but having that idea of working together. We want solution focused. We want partners that don't just represent themselves, but represent the community and others like them. and that are open to learning, having a teaching experience, knowing that we don't know everything as providers, and patients don't know everything about healthcare as well. It's really important to have people that have a passion for patient-centered care, that can listen to those differing opinions and can take positive, negative experiences in a constructive way. And also respect, promote, and maintain strict confidentiality. This is a trust piece of that engagement. Phew, okay, so I'm 1 minute over. Thank you guys for hanging out with me. I want you to, are there any questions before we wrap up? I'm happy to stay on and answer. So please feel free to unmute or type in the chat.
While people are thinking of their questions, I was just going to say, early on in your patient family engagement activities, don't forget to be transparent. If this is the first listening session that you're hosting, or the first interview that you're doing, share that with the patients or family caregivers, or community members that you're talking to really bring them into the process of engagement too. It helps enhance that relationship and trust building further on. So transparency is key early on. Bring people into the mess that is the start of engagement.
I love that. Bring people into the mess. Thank you, Lindsay. Hey, well, our next session's not going to be as fun. Sorry, I have a great bias against data. Data is kind of boring. I like to see the work and the fun stuff. But reach out anytime to me for more information. There'll be a link in the slides to the assessment. Our next session and our last session will be May 23rd. And we will provide a link of resources that were talked about plus more in this presentation. So thank you all so much for hanging out with me. I appreciate it. And I hope you have a great day. I know you love data, Zoe. I'll lean on you. So thank you all. Have a wonderful day, and we will talk next week.
Thanks, Jennifer. Thanks, everybody.
Thanks for joining us, Lindsay. I so
Of course.
appreciate you.
Of course, anytime.